morning and welcome to today's NCPDP webinar, Hospice Provider and Medicare Part D Walkthrough. You can ask a question at any time during the webinar by typing in the question pane on your GoToWebinar toolbar. All questions will be addressed at the conclusion of the webinar as time permits. After the webinar, you will receive an email with a PDF copy of the slides. Our speakers today will be Mary Perez, Lead Systems Analyst, Medicare Part D Enrollment, Magellan Rx Management; Nancy Bridgman, Director of Medical Billing, Remedi SeniorCare; and Judy Lund-Person, Vice President, Compliance and Regulatory Leadership, National Hospice and Palliative Care Organization. I will now turn today's presentation over to Mary.
And next slide, please. Good morning. Our first task is to identify and define NCPDP and hospice. So the National Council for Prescription Drug Programs provides a forum wherein our diverse membership can develop solutions, including ANSI-accredited standards and guidance for promoting information exchanges related to medications, supplies, and services within the healthcare system. Under NCPDP is our NCPDP Workgroup 9 Government Programs Hospice Task Group, and it's a forum for hospice providers and associations, pharmacies, and Part D plan sponsors to collaborate on the industry challenges faced in the Medicare hospice benefit. Now I'll turn the presentation over to Nancy.
Thank you, Mary. And good afternoon, everyone. I'm really glad to see so many people have joined us today. Again, thank you. It's appreciated. I'm Nancy Bridgman. I'm with Remedi SeniorCare, and as Brian introduced, along with Mary Perez of Magellan Health and Judy Lund-Person from the National Hospice and Palliative Care Organization, we'd like to take you along the path of the hospice enrollee experience with respect to the Medicare Part D world. Okay, so we're gonna include a lot of information today. Slide, please. We'll start with some background, let you know how we got here. Then we're going to move through the process of the notice of election, continue through the interaction between the hospice providers, the Medicare Part D plans, and the dispensing pharmacies, including the use and the importance of the Hospice Information for Medicare Part D plans form. We'll talk about that being used prospectively and retrospectively. Then we'll go into what our expectations are. What are the actions based on the submission of that A3 or the Hospice Information for Medicare Part D plans form? And through the industry, it has been commonly referred to as A3. So just for you folks out there, you understand that this is the form that we've been using and talking about for a while. And we'll also touch on the retroactive review of Part D paid claims. Okay, so slide. Some background. The OIG, or the Office of the Inspector General, did a analysis of some claims dispensed in 2012. The results of that showed that there were a lot of claims billed and paid by the incorrect Medicare benefit. Okay, we all know there's Medicare A, B, C, and D. All right, you've got A, which is your hospitals, hospice. You got B, which is the doctor's office, the DME. C is your Medicare Advantage plans, and of course D is your prescription drug programs. Okay, if an item is covered in one of those benefits, it can never be covered in any other benefit. So their findings showed that there were a lot of Part D plans that were paying claims that should have been covered by the hospice Part A benefit. Now, there's a lot of reasons for this, for the misapplication of the payment responsibility. There were a lot of reasons then, and there's still a lot of reasons that happens. And we're going to touch on those throughout our session. But CMS then intervened in an effort to reduce the occurrences of the misapplication of payment. They released guidance in 2014 indicating that the Part D plans were required to validate payment responsibility for 4 categories of drugs most commonly used in hospice care. Those 4 categories: analgesics, antiemetics, laxatives, anti-anxiety. We'll refer to those a lot throughout our conversation today. So they identified 4 categories of the hospice drugs, and they strongly encouraged the Part D plans to place a prior authorization requirement on their patients known to be in hospice and that receiving a drug in one of those 4 categories of drugs. So the plans were to impose edits. So when they received a claim from a beneficiary that they knew was hospice, and that claim just happened to be for a drug in one of those categories, they would deny this claim with a reject code A3. Okay, the definition: this product may be covered under hospice, Medicare Part A. And they required a prior authorization or some kind of confirmation that would say that that's not true in order for the claim to be paid. But, you know, as with everything, there's always an exception. There were circumstances identified where the drugs in these categories were being used by beneficiaries in hospice, but their use was unrelated to the terminal illness. And because of that, they were not covered by the hospice benefit. So we were kind of in a quandary. How do you accommodate these situations? So NCPDP, along with CMS, developed a form. It was published in 2014, entitled The Hospice Information for Medicare Part D Plans. And because it was used with that A3 reject, a lot of people through the industry have now just referred to it as the A3 form. Slide, please. So basically, that's the background. That's how we got where we are today. A lot of collaboration between CMS and NCPDP, a lot of collaboration with hospice and Part D plans. And we'll kind of walk through what the responsibilities are for each of these different groups. We'll begin the journey by talking about hospice responsibility. So when a beneficiary chooses to enroll in the Medicare hospice benefit, the hospice needs to conduct a medication review during that process. And as a result of that, they would create a written comprehensive assessment. This includes the plan of care, okay? These are the medications that will be dispensed to this beneficiary. And then they also have to develop a plan for discontinuing medications that they determine are not medically necessary. And once they've done this assessment, they've decided what medications the patient will be receiving as part of their plan of care. Those that are not medically necessary, they're going to discuss this medication coverage and the management with the patient and the concerned family members. This is all during that admission process. They will explain that hospice will pay for all the drugs related to the terminal illness and related conditions included in the plan of care. But one conversation that has to be had with those folks is that if a drug has been determined not medically necessary, hospice does not pay for it. If the family member or if the patient themselves determines they want to receive that drug anyways, it becomes the responsibility of the patient. So it's important that that conversation, that piece of the discussion is had with family and member. Okay. So now they've done all of these things. They've had the conversation. They have a written comprehensive assessment. They know what the plan of care is. Now they need to complete and submit that notice of election to CMS. Slide. I'm not the expert on notice of election, but I know someone who is, and that's Judy Lundperson. So at this point, I'm going to turn the mic over to Judy to take you on the notice of election journey.
Thank you so much, Nancy. So as we are thinking about the notice of election, I thought we might start by a little history lesson. So we know back in the day, as Nancy was talking about, that we were seeing a lot more Part D paying for hospice drugs after the patient had elected hospice. We knew that before we saw the OIG report and anything else. So the notice of election was originally designed to communicate to other Medicare provider types, including Part D plans, that the patient was on hospice. And Part D was our very highest priority communication for the notice of election, which is why that 5-day notice timeline is in the final rules. So we had notices of election submitted through DDE or direct data entry, and then on January 1, 2018, CMS began accepting the notice of election electronically. We've seen some significant increase in hospices being able to use the electronic submission, although we heard in the early days earlier this year that a lot of providers were still nervous about submitting their notices of election electronically for fear that they would get waylaid somewhere and would not get to their proper destination at the MAC on a timely basis. So we know as well that the notice of election information goes into the common working file. I think one of the things that our group at NCPDP has learned very, very well is that the common working file takes a while to communicate with the Part D system called MARCS. So the common working file updates will go from CWF to MARCS, and then it may take some days before the plan actually knows that they are they've got now a patient who is on hospice who is also one of their plan members. So the plan, the Part D plan sponsor gets their information in what we call a TRR, or a transaction reply report. They get that any number of times a week. Most often they get it daily, especially on business weekdays. But it may take a while before the information is up to date that the patient has elected their hospice benefit. So that's our challenge as we are continuing to work on this, work on the timing of the communication, and certainly in our communication with CMS, we've talked about how important it is to shorten up the time that it takes for the common working file information to get all the way to the plan. So Nancy, I'll turn it back over to you.
And thanks, Judy. Very informative. So, basically now we know that the hospice has done their assessment, and the NOE has been sent off to CMS to start its journey through that common working file, the MARCS file, and ultimately to the TRR. But how do we know the payment responsibility for these beds? Okay. We're going to try and help you out a little bit there. We have a grid here with a scenario. So if you'll change the slide, please. Okay. So the first scenario is pretty easy to determine. If the drug is part of the plan of care and it's related to the terminal illness, then the payment responsibility belongs to hospice. That's pretty easy, pretty clear cut. It's part of the plan of care. It's related to terminal illness. It's hospice responsibility. But we have 3 other categories here that all concern unrelated drugs. And we're talking unrelated to the terminal illness. So the first scenario is unrelated to terminal illness, not included in the 4 categories requiring review. So remember, we have the analgesics, anti-nausea, the laxatives, the anti-anxiety. Those all require review by the plans before they pay the claim. But these are claims that are unrelated to the terminal illness, but they're not in those 4 categories. What happens? Well, the pharmacy is going to submit their claim to the Part D plan. And the Part D plan is going to, based upon the plan's formulary requirements, plan limits, etc., that's how they'll adjudicate the claim. They do not apply an A3 reject at this point because, again, this is an unrelated drug that's not in one of those 4 categories, so it does not require review. So ultimately, Part D ends up paying for these claims. Again, all the plan requirements have to be met for that to happen. Next category is the unrelated to terminal illness, but in one of 4 categories of drugs that do require the review. So these are those in one of those 4 categories, but hospice has said it is not the plan of care. In the plan of care, it's unrelated to the terminal illness. Pharmacy submits the claim, sends it on to the Part D plan. The responsibility for payment of that claim is going to be the Part D plan, but only after that's confirmed by hospice. So in other words, when that goes in, they're going to look at it, they're going to say, I know this beneficiary is in hospice, and this is in one of those 4 categories, so I'm going to deny it with an A3 rejection and require that prior authorization review and information from the hospice. If the plan is performed or notified proactively that this is an unrelated to terminal illness med, they're going to go ahead and process that claim without the A3 rejection. But if they don't now, you're going to get an A3 rejection, and when the hospice confirms that it's unrelated to the terminal illness, the payment responsibility will rely on Part D plans adjudication. And again, it still has to meet all of their plan requirements with regards to formulary, plan limits, etc. The last unrelated category is that it's an unrelated to the terminal illness, and hospice determined this drug to be no longer medically necessary, but the patient wants it anyways. Okay, we've kind of mentioned that when doing the assessment. You know, mom still wants or to receive this drug. Her family thinks she should still get this drug. Hospice has had the conversation saying that we don't think it's medically necessary, so that if you receive this, it is going to be your responsibility to pay for that drug. Okay, so we have drugs identified in plan of care as related to the terminal illness. Those are hospice responsibility. Unrelated to terminal illness, not in one of the 4 categories, those will be sent on to Part D. Unrelated to terminal illness, but in one of the 4 categories, they will be they will have review done, all right, to make sure that it is an unrelated, that it's not included in the hospice bundle, and again, ultimately ends up with Part D. And those that are unrelated to the terminal illness, but considered no longer medically necessary, are the responsibility of the patient. And just a little reminder, we talked about those 4 benefits offered by Medicare, A, B, C, and D. But for prescription drugs to be covered under Part D, when the enrollee has elected hospice, the drug has to be for treatment of a condition that is unrelated to the terminal prognosis of the individual. Okay? So next slide, please. So for hospice, how do we communicate between the hospice and the Part D plan? How do you know which Part D plan it is that the beneficiary is enrolled in? Well, the first area you're going to investigate for that is, does the beneficiary or a family member have a copy of their Part D insurance card? That's the easiest way. Copy can't be found, you don't have it, that's an issue. But if they do have the card or a card, make sure that we're looking at a prescription drug benefit card, not a major medical card, okay? Often confused. But in the event that you cannot get a copy of their card, if your hospice uses a PBM, a benefit manager, then they can ask their PBM to perform a Part D eligibility verification. Your PBM is going to require a little bit of information, the patient's name, their date of birth, their ID number, and we're going to look for a HICN or an MBI. The new MBIs have started to go out. I think maybe also a zip code, but the PBM will tell you what they need. You contact them and ask them to run an eligibility verification. You don't have a PBM, reach out to your dispensing pharmacy. They do have the ability to perform that same Part D eligibility verification. So if you don't have the PBM, go to pharmacy. So there's 3 different routes by which you can find out the Part D plan that you need to contact. But then how do you know who to contact at the plan? Well, if you have the card, there's a help desk number on the card. If you don't have the card, a help desk number is returned with the eligibility verification. So make sure you get that number from your PBM or from your pharmacy so you know where to start. You're going to call that number, and yes, we know that there are often difficulties in communicating what you need to the plan, making sure they understand, but that's your starting place. You're going to need to get a fax number. You can ask for a department or department extension that is able to approve your request or take a written statement or a verbal statement to approve your request. But again, you're going to contact them. You're going to start off with that number that you receive back from the eligibility verification or that's on the card. Next slide, please. Right, so now I've reached out to the plan, and I need to communicate the information with regards to the unrelated drug. And how do I do this? Okay, because you know what? Sometimes plan and hospice are on a different page. They talk a different language. They don't understand what the other one is trying to tell them. We have a form here that we can use to send into the plan. Okay, so your number 1 course of action here is to complete that hospice information for Medicare Part D plan, widely recognized as the A3 form. Hospice, make sure that your employees are familiar with this form. They need to know why they're completing it, what information is required, and that they need to be sending that into the Part D plan. Very important. Next slide, please. The primary uses for this form: document the drug that is unrelated to the beneficiary's terminal prognosis. Okay, number 1, you're going to let the Part D plan know this is an unrelated drug. You can convey the beneficiary's change in hospice status. You can tell them that they just submitted the notice of election to become hospice, or you've just turned in a notice of termination or revocation, and the patient is no longer hospice. You can communicate and update the medications list from the beneficiary's plan of care. You can let them know everything that that patient has taken and identify the financial responsibility for each. Next slide. So what I kind of want to do here is to go over the form itself. It's a 2-page form. Page 1 is mandatory. It's required to be submitted, but page 2 is optional. So section 1 is page 1. It's the hospice information to override a hospice A3 reject or to update hospice status. And Brian, if you can move forward 1 slide here. This is a cutout from the top of that form. Okay, so section 1, part A, purpose of the form. You need to check all appropriate boxes. Is this an admission, newly elected hospice benefit? You're proactively sending prescription communication. You're giving them the meds that the patient will be using, or you're using it to override that A3 reject. Pharmacy has called you and said, I have a reject. Can you please complete the form and send it to the plan? Or termination of benefit. And these are the folks that you just submitted a notice of termination or revocation to CMS. So all 4 of these could apply, or maybe 1 or 2, 3, whatever. Check off all the appropriate boxes and then include the information from the Medicare Part D plan and from the hospice provider. Okay, please include the hospice name, the address, phone numbers, fax numbers, your MPI, and most definitely a contact name at the hospice in case there's questions or concerns from the plan. As far as the plan information goes, you've got that information from your eligibility verification. You've got a plan name. If there's a PBM name that's associated with the Part D plan, phone number, fax number. If you have a secure email, you can include that. And also, if you know the contact, and like an attention to at the plan. The last box there, the plan sponsor website link, that is totally optional. Okay, doesn't have to be entered. You don't have to complete it. Slide, please. So Section 1, Part B and Part C involve, Part B is patient and prescriber information. Part C is with regards to the hospice pharmacy benefit manager. Slide. So this is Section B and C. All right. So you're going to include the patient information, patient name, date of birth. It says the patient ID, and it's got the HIC and the HICN in quotes, but we now also have the MBI. So if your patient already has their MBI, please do include that. Their admission date to hospice, or as it applies, or the discharge date as it applies. The principal diagnosis code, other diagnosis codes if you have them, and if you're telling them about unrelated meds, do you have a diagnosis code that applies to those? Prescriber information, you've got the name, NPI, their practice name, practice address, contact name. Is it the, maybe it's the office manager that would be the contact. The phone number, fax number, and you also want to indicate whether this prescriber is affiliated with the hospice or not. Maybe it's Mrs. Jones's personal physician, and they're not associated with the hospice. But please make sure that that is checked. You'll see the next box. For change in hospice status, update documentation is required. Please check to indicate which document is attached. So you've just completed that notice of election and you're sending it on to CMS. Send it on to the Part D plan as part of this form. Make a copy of it and attach it to. So you're telling the plan that your patient is now enrolled in hospice. Or on the other side of that coin, if the benefit has terminated or been revoked, you're going to send a copy of that notice of termination along with this form. Okay. Part C, hospice pharmacy benefit manager information, totally optional. It is not necessary that that particular section be completed. Slide, please. So Section 1, Part D, that's that prior authorization process. That's where we're going to inform the plan of those unrelated drugs. Okay, and you can move this slide on, Brian. It's important that you use a separate line for each of those meds that you're informing of the unrelatedness, okay? So Part D, prior authorization process. Enter a separate line for each analgesic, anti-nauseant, or antiemetic, laxative, and anti-anxiety drug. Those are those 4 categories of drugs. Enter each on a separate line to show that that medication is unrelated to the terminal prognosis. If your drug is outside one of those 4 classes, you're not required to do that prior authorization. Remember, those that will not get that A3 reject. So you're going to put in the medication name, the dosing quantity, and the last column is the rationale to support the medication is unrelated to the terminal prognosis. This is optional. Initially, CMS had wanted some more information, but determined that this is a lot to ask, a lot of information to go in there. The fact that hospice has already done an assessment and has created a plan of care, they've done their homework, they've done their background, okay? And if they're saying this is unrelated, it's unrelated. So it's not necessary to put your support information in that box. You'll have that as part of your medical records for your beneficiary. So if there's a question or an audit, you already have your backup. You know, you could put just the letter U, or you could put unrelated. That would be perfectly fine, okay? It is not necessary to put all of your support information there. Slide. The last section, Part E, is the signature of the hospice representative or prescriber. Slide. So you're going to put the name, the signature of the hospice representative and the date. And then you also need to include their position title, right? For the prescriber, okay, you'll have their signature there. If you've got a prescriber that is not related to the hospice, they'll sign and date. And then you need, this is kind of like an attestation. You need to respond to the question that they're asking. If the prescriber of the medication is unaffiliated with the hospice provider, has the prescriber confirmed with the hospice provider that the medication is unrelated to the terminal prognosis? It's very important that that be answered. Okay, so you want to make sure that is checked off. Very important. Slide. Okay, that was the completion of Section 1. That's the first page of the document. Section 2 is the plan of care, and as you see, it's optional. Slide, please. You're going to enter the hospice name, hospice MPI, the patient name, their ID, and their date of birth. Okay, it's pretty important that this gets filled out. It's not as in-depth as on page 1, but we want to make sure that if perhaps page 1 and page 2 get separated during the fax or during filing, that the plan will still be able to identify the patient or their enrollee that we're sending this information in for. Slide. Next slide. So now we have an area on the form that is for additional medications under the hospice plan of care and its designation of financial responsibility. All right. So these are those drugs outside of those 4 categories, and the hospice has determined they will be a part of the beneficiary's plan of care. You're going to list the drugs, the medication name, and the strength, and you're going to indicate whether or not this is a hospice or a patient responsibility. Because, again, as we mentioned in the past, you know, mom or a family member may decide that they want to continue those meds even though hospice deemed them not medically necessary. So if they're continuing it on and it's not part of the hospice plan of care, it's not medically necessary, you'd list it here and indicate it as a patient responsibility. So this completes whatever meds are available as the plan of care for the beneficiary. Very important. This would be great to have it filled out and sent on to the plan. At the bottom of the form, you'll see there's a signature of the hospice representative, so you're going to sign it and date it. If you've identified claims as patient responsibility, and remember we've had the conversation with the family members, you want them to sign this so they're saying that they are aware, and you've identified it as patient responsibility and they're agreeing. So you're going to have a beneficiary or their representative sign the form as well. Slide. So hospice, you've gone through the trouble, you've completed the form, okay? Now what are you going to do? All right. Well, first recommendation is a prospective submission. Right. By submitting this form to the Part D plan, as soon as you have that notice of election, you're going to prevent that claim that's unrelated from rejecting at the point of service when it's designated as unrelated. Okay, so you're going to skip a whole step in the process there. Plans, you need to accept that form. You need to use the information that's in that form to satisfy the prior auth requirements for the drugs that hospice designated as unrelated. You get that form faxed to you, you need to use it. Don't confuse this with coverage determinations. This process doesn't need to comply with coverage determination timeframes and notice requirements. Okay, and again, this should prevent, if you're receiving this prospectively, this should prevent the A3 rejects for drugs that are designated as unrelated. Slide. Hospice, if you're sending this in because the pharmacy submitted a claim and they got an A3 reject and they were on the phone saying, I can't get paid, can you please comply with this? You're sending it in response to that A3 reject. You haven't done it prospectively, okay? So the plan can't make a determination whether the drug is related or unrelated, and a claim's going to deny with an A3 if it's in one of those 4 categories: analgesics, anti-nausea, laxatives, anti-anxiety, okay? It's going to deny with an A3. Product may be covered under hospice, Medicare A. Pharmacy, as I said, is going to call you or the beneficiary, depending on the situation, and let you know that there's a rejection and that you need to complete the form and submit it to the Part D plan. Part D plan, you need to accept this form for any drugs that are listed as unrelated, and you need to allow normal processing of the claim. Receipt of this form with the drug in question, this is signed by the hospice, you need to immediately accept it and allow for that claim to process. Slide. The other use of the form, you're communicating a beneficiary's change in their hospice status. Judy spoke to the lag time, that process of sending in the NOE, and then the NOE goes through the common working file, and then it goes to marks, and then eventually it gets to the TRR, which gets to the plan, okay? You're communicating a beneficiary's change in hospice, and you send it in as soon as that happens. You include a copy of either the notice of election or the notice of revocation, whichever applies, okay? The plan can use this as best available evidence. And for any plans that are on the phone, I'm sure you're familiar with best available evidence with regards to our copays and the LIC status and et cetera. Well, this is best available evidence, okay, for that hospice beneficiary. The information should be reflected in the plan system until your TRR is received. It allows you to start immediately looking at the claims for either a hospice beneficiary or one for which hospice has been terminated. So hospice, you're communicating that there's a hospice status change. Plan, you need to take this information and you need to get it entered in your system as soon as possible. This applies until you get your TRR, and your TRR dates should be matching the same dates that you received from the hospice. Okay, slide please. And again, just a little bit more elaboration. You know, if the patient's coverage for hospice has been terminated, what this does is it allows the plan to adjudicate the claims without imposing those edits that result in the A3 reject for the hospice category drugs, okay? Because they're no longer in hospice, so that doesn't apply. It helps them to better manage the care for their enrollee. If it's an election notification, it allows the plan to begin adjudicating claims with the edits in place for those 4 categories for the drugs that are most commonly used by hospice. What does that do? Well, you know what? They're not going to get notified of that notice of election for maybe, and this is a number I'm drawing out of thin air, so please don't hold me to it, but let's just say it's 14 days down the road when they finally get a TRR that says their patient is in hospice. What this does, it circumvents that 14-day lag time. They immediately start imposing those edits so that we don't have an issue on down the road where Part D has paid for a claim that should have been hospice responsibility. Okay, next slide, please. Another use of the form, communicate medications listed on the plan of care. All right, so these are the meds that are, you know, hospice, you've created your plan of care. These are the meds on page 2 that's telling them, yes, this is going to be in the plan of care and it's a hospice responsibility. Yes, the patient is going to continue to receive this medication, but it's not medically necessary, so it's the patient's responsibility. Okay, really, the best scenario is that this gets to the plan prospectively. You can identify related or unrelated status for the drugs. You're identifying financial responsibility. In plan, you need to accept this. and use this in your utilization review and coordination of care activities. Just as we spoke to the fact that the hospice folks need to be familiar with this form, your staff members at the Part D plan need to also be aware of the uses of these forms. They need to become familiar with it, what they do with it, how it moves on down the line, and how it helps you manage your patient's care. At the same time that you're prospectively sending this to the Part D plan, you need to also send this on to your dispensing pharmacy. They need to know who's responsible for these meds as well. They need to know who to bill. They need to know, because it definitely is on the plan of care and it's a hospice responsibility. They know, don't even send that to the Part D plan. It's going to be billed to the hospice. If it's patient responsibility, they know that up front. So now they know who to bill appropriately for that, instead of sending it on to the hospice and then getting notified later and having to do credits, charges, etc. Okay, pharmacy now also is included in the loop, and they know. They have those dates of effectiveness. They have the dates for the termination. They know whose financially responsibility for the drugs that they're sending out to their patient. Slide, please. So bottom line, this form is giving all of us a uniform way to communicate. It's a uniform way for the hospice provider to provide initial and updated drug profiles to the Part D plan. And again, plan, it's important for you to be aware of all of the drugs which the beneficiary will be taking, as well as the source of the payment for each drug. You need to be accepting and utilizing the information to appropriately and more accurately adjudicate claims for the hospice beneficiary. This is vital information for everyone concerned. Both hospice and plan need to be educated in its use, its purposes. Slide. And again, a little summary here. Who are the users of this form and the recommendations for its use? For the hospice provider, to prospectively provide unrelated drug information to Part D plans, or to provide information to override the A3 reject, to report any changes in the beneficiary's hospice status, and to report plan of care information. Slide. For the Medicare Part D plan, you can prospectively satisfy PA requirements for a member enrolled in hospice. You can use it to override the A3 reject that was put in place. You can process a change in the hospice status, knowing when their effective date of enrollment or effective date of disenrollment or termination. You can use that plan of care information to better manage your enrollee. Slide. And pharmacy providers, they're kind of in the middle, okay? And their purpose is to make sure that that beneficiary has access to all the drugs, not just the unrelated drugs that deny. We certainly want to make that happen as soon as possible so they can get it out to their patient. But the pharmacies, they're in the middle, and they need to know just as well as everyone else, financial responsibility, what's covered, what's not covered. And this is going to help them make sure that their patient is getting the medications that they need as quickly as they can. Slide. And I'm going to reiterate again, just as we emphasized that the hospice providers should utilize the form, educate their staff. That also needs to happen on the Part D plan side. Educate your staff in the acceptance and utilization of the form. Pharmacy, become familiar with this form, know how to use it. If you've got an A3 reject, know what you're asking the hospice to do. Use of this form by both the hospice and the Part D plans can significantly reduce the need for retroactive recoupment. We talked about circumventing that lag time in the plan's notification. There's 2, maybe 3 weeks of time where claims can be appropriately adjudicated and paid by the correct responsible party, as opposed to having to look at those retroactively and say, oh, maybe I shouldn't have paid for that, okay? So using this form is really going to help us with that retroactive recoupment process. Slide. The retrospective review of those Part D paid claims. Hospice, the plan's not out to get you. Okay, they're doing audits because they're required to do audits. Sometimes they use an outside source, sometimes they use internal. But they are required by CMS to do these reviews of their Part D claims, okay? The look-back period is about 36 months, except for the case of when there may be some illegal activity or fraudulent activity, and then there really is no time frame, but I think we can all understand that. The first thing that's going to happen is there's going to be some outreach to the hospice providers to confirm whether Part D did pay claims that were actually part of the hospice bundle on data service. And again, those could be those claims that fell into that period of time before the TRR finally made it to the Part D plan. Slide. So now the hospice gets notified. They need to say yes it was or no it wasn't. And then there's a notice that'll go to the hospice that's requesting reimbursement of claims confirmed to be the hospice responsibility. With that request, you'll be asked to make your payment within 45 days of the notification. The appeal period is 30 days. Okay, so just touching a little bit on that retrospective review. Not going to go into a lot of detail at this time, but what I can say is that if we go back to the beginning of our presentation and we look at the form, we see that it gets submitted timely. When you send your NOE into CMS, send that same, complete this form, send the NOE or the notice of termination, whichever it might be. Send all of that information onto the Part D plan. We're going to reduce that retrospective review, reduce the number of times you're going to be asked to reimburse for claims paid by the inappropriate Part D or Medicare benefit. It's going to help pharmacy better identify their hospice patients and appropriately bill those claims. So fill out the forms, send it into the Part D plan, send it to your pharmacy, make sure everybody has the information up front. And any changes that occur, send the form, letting them know that there's been changes. We all know that a hospice patient can change medications frequently. So anytime that happens, let's inform our Part D plans. Let them know. And plans, the hospice has taken a lot of effort to complete these forms and to give you this information. Please accept it and apply it in your systems so that you can manage your enrollee. Slide. So at this point in time, I'd like to turn the mic over to Mary Perez to take us through the rest of our presentation. Mary?
Thank you, Nancy, and thank you for all the information you've provided for both the hospice and the Part D plans. It was very informative. We wanted to also note our accomplishments that we've made with NCPDP as well as CMS. So we've had a lot of industry collaboration with CMS, hospice providers and associations, PBMs, pharmacies, Medicare Part D sponsors and plans and PBMs, as well as vendors and processors. Through our hospice task group, we have helped CMS develop the hospice information for Medicare Part D plans form and instructions, which was sent to all of the webinar registrants. So please utilize that. Also, starting in 1/1/2019, Medicare Part D plan hospice contacts will be available at HPMS, also known as the Health Plan Management System. So that's a great accomplishment for those hospices that were having trouble finding Medicare Part D plan hospice contacts. Next slide. So the next steps for our hospice task group is that we'd like to continue our collaboration for process improvement. We also have been asked by CMS to develop a standardized hospice collection notice. And then also we plan a future webinar on retrospective review. It's a large topic, and so we didn't feel like we could give it justice by just including it in this webinar, so please look forward to another webinar. Next slide. So all the resources are in the webinar today, and this presentation will be sent out as well. We provided the CMS link to the Hospice Center information there at CMS, as well as the National Hospice and Palliative Care Organization, our NCPDP organization home, as well as the NCPDP Collaborative Workspace. The Collaborative Workspace is for anyone to join. You do not need to be a member of NCPDP. It provides our task group information. It has all of our notes from our meetings, as well as any guidance or work that we're doing within the hospice task group. So please join the collaborative workspace and place the hospice task group in your profile and join us for future meetings, because we would appreciate all folks to join and help us collaborate, and as stated previously, start working on our hospice collection notice. Next slide. So this leaves us open for questions, and so we have a few minutes to take some, and if we're not able to take all the questions today, you're welcome to send those to NCPDP, and we'll be happy to answer those via email. Brian?
Thanks, Mary. Yeah, if we don't get through all the questions, what I'll do is I'll transcribe the ones that we don't and put them into a document and send them to you guys, and then you can answer them, and I'll send them back out to everybody.
Thank you.
Our first question is, in the literature and conversations with CMS, they use terminal prognosis in determining related or unrelated. So is it terminal illness or terminal prognosis or both?
It's both. So it's what's determined in your plan of care, what the hospice determines in their plan of care, and what they send off to CMS. Notice of election, and et cetera. But it truly is terminal illness and terminal prognosis. Use both.
All right, our second question. What if it is related? What if it is a related drug but determined no longer medically necessary by the doctor and the family is not ready to discontinue the drug? Who would be responsible for payment?
I'm not sure I understand. So it is a related drug?
Yeah, it says, what if it is a related drug but determined no longer medically necessary by the doctor and the family, and is not ready to continue the drug?
Well, I mean, if they're no longer dispensing the med, then there won't be any claims to submit. So the determination of financial responsibility won't be there. So hospice, if you say it's related, but through discussions, it's determined ultimately that, you know, mom just isn't going to get this med anymore, then that's okay. So you want to discontinue the med, and pharmacy should no longer be filling prescriptions, filling orders for that particular medication. Use the form. Go ahead.
No, so Nancy, I was thinking that I think the question is, the doctor said we recommend discontinuation because this is no longer necessary, but the family doesn't want to discontinue. So I think then talk about it from the perspective of patient family pay.
Right, and that's exactly it then. If that's the scenario, okay, so hospice has now determined that it is no longer medical necessary, then that's the route we're going to travel. It is no longer part of the plan of care. Okay, and financial responsibility then is lies with the patient. And again, you need to make sure that you send that form to the Part D plan to let them know now that this particular medication is the patient's responsibility. Also let your pharmacy know that there's been a change and this is now patient responsibility.
All right, next question. When is CMS going to provide the contact list for all Part D plan sponsors that they have said they would? This would facilitate earlier communication and avoid the hospice getting bounced between several people when they call the Part D plan.
I believe that plans have been mandated to provide a hospice contact with an effective date of 1/1/19. So January 1st of 2019, there needs to be a hospice contact in place for each of the Part D plans.
All right, our next question. It looks like we need to send the PBM a copy of the NOE. Is that correct?
If you're sent, it would be a good thing to send it, yes, all the time. But in particular, if you're sending in prospective information, you certainly want to include the notice of election or the notice of termination. They have dates on them, and the plan can use that. Okay, so instead of waiting for that information to come via the transaction reply report, they're going to get it directly from hospice. So they're getting it from the horse's mouth. They can enter those dates and allow claims to process correctly.
All right, our next question. Will the form be updated for MBI?
I'm thinking that's a good question, because I think that's probably a good thing, because we use, whenever it's referred to as an ID, you're going to see the HICN in quotes. And we really need to be able to include that MBI as they're distributed, as they're assigned to the beneficiary. So it is a recommendation we will make to CMS to update and to note that there's going to be until, I believe, April of next year before all the MBIs are distributed. So there'll be some overlap where either the HICN or the MBI, either one can be submitted. But yes, we'll make sure that CMS makes a notation there to include MBI.
All right, we have time for just a couple more. Is the physician SIG required or not? Only hospice representative?
Okay, so you're probably talking on the bottom of section 1, page 1. It gives you a line for both the hospice information and the physician information. Only the hospice information is required if hospice has made all of these determinations and the prescriber is affiliated with the hospice. If the prescriber of the particular medication that's unrelated is not affiliated with the hospice, he needs to sign this form, and he needs to confirm that he did talk to the hospice and looked at their plan of care and he agrees. Okay, so that physician signature is really when the prescriber is not affiliated with the hospice and has prescribed a drug hospice has determined to be unrelated.
Now, it is the top of the hour. Do you have time for a couple more, or should we just go ahead and transcribe these and send them out later?
Me personally, I think we could do a couple more if folks are willing to stay and listen.
Okay. The next question then, what is CMS doing to educate Medicare participants about this?
What is CMS doing to educate?
Correct.
You know what? I'm not sure. Certainly a question that we need to ask. We can look into. We almost always have CMS participation on our hospice task group calls. So any questions that we have of CMS, we usually can ask and get answers quite rapidly, or we'll send them a letter, an email, requesting answers to questions.
All right. We'll do one more. Is the form available in XML or schema?
I don't know. I'm thinking it may be, but I don't know. But it's certainly something that I can investigate, and I'll find out, and Brian will get back to you with my answer.
All right. The rest of the questions I'll transcribe, and I'll get those out to all the attendees as soon as I can. So that concludes today's webinar, Hospice Provider and Medicare Part D walkthrough. I'd like to thank our speakers today for their time and expertise, and thank you all for your participation. Have a good day.
And Brian, if I might, before everybody disconnects, if
Sure.
there is a need, if there were folks who weren't able to make today's call, and a need is out there, we will replay and do this session again. So if you know folks that want to, if we hear through the hospice task group, we can certainly do the presentation again. And I echo Brian's thank you for all of you joining and the good questions, and hope to hear you on the hospice task group call. Thank you.